So welcome everybody. This is Doug McCall from the International School Health Network. Welcome to this session on COVID in schools, a postmortem and development of a framework to prevent infectious disease outbreaks in the future. We're really pleased to be welcoming three of our presentations this morning. And I'm just hoping that Joel Kettner has got back into the room so we can start on time. But maybe as I'm waiting for him to come back to the session.
I'm here. Can you hear me?
Yeah, just not, there we go. Yeah, okay, that's great. Okay, so just very briefly in terms of the purpose of the session, it's learning from the COVID experience in terms of the school context, the school setting, and then also looking forward to developing a framework for future outbreaks of infectious diseases. Really pleased to see that WHO is working on the same idea of trying to generalize all the different infectious diseases. They have to be treated specifically, but in the school setting, the responses are quite similar. So I'm really pleased that seems to be part of the trend moving forward. And I'm not, somehow my slides are not moving forward. Sorry, this is I think this is a non-Zoom problem, but I'm not sure why they're not moving forward. All right. Oh, there we go. Just slow. So our three sets of speakers, Joel will start us off, and Peggy and Heather will be talking about the Newfoundland experience, and then Daniel and Mark will be talking about a study they've done in several countries. In essence, and if you look at later on down that slide, we're looking at building a multi-component approach to infectious disease prevention in the schools, and usually it involves elements such as policy, education, obviously in school, vaccination programs in school or in the community, and so on. It's a multi-component approach, multiple interventions. The list of infectious diseases is many, and they're not, as I say, not treated in the same way, but the prevention activities in the school are often very similar. We use the term multi-intervention program to describe a set of interventions like this. It's a jargon that we've tried to develop to clarify as being distinct from a healthy schools program, which is a broader set of, it's a combination of these kinds of multi-intervention programs on different issues. And in the FRESH framework, the FRESH partnership is a group of UN agencies, NGOs, and donor organizations, and we've developed 15 different what we call these multi-intervention programs on different themes, and some of them you'll see relate to infectious diseases. This is the scary list of multi-component approaches and multi-intervention programs that are often delivered in schools. And you see on the right-hand side, the infectious disease, and it can be delivered in different broader frameworks, such as indicated by those arrows. So I'm going to give up sharing my screen and pass over to Joel, who will begin his remarks. Joel, you should have control of the screen.
Okay. How are we doing? Can you see my
great.
First slide?
Great.
Okay. Okay, well, I think the take you're going to hear from me, maybe it's a little different than expected. I'm still not sure what I think about all this. And I didn't take as much time as I should have to prepare this, which is why I probably have more slides than I should. But I'll go through them quick enough so that I cover what I'm intending to do. Anyway, I'm a public health doctor. I'm not hired by government right now, so that means I'm not really a medical officer of health, which is a legal position. And instead, I'm more of a teacher and other things related to that. So a few caveats and disclosures. And I'm going to add one right now, which is that I'm looking at this from a perspective of the experience in Canada, and particularly Manitoba, the province that I'm in. I'm sure that the things I'm going to say in many ways do not apply to other countries. And so I need to make that clear. I'm going to talk more in general about the response to COVID and my questions and concerns about it, as well as what I think is understanding a public health approach using a settings framework. So I'm not an infectious disease specialist. I'm not here to praise or bury government policies. This is very important, especially since this is being recorded. It may sound like I'm criticizing things that were decided or done by governments or public health officials. I'm not. I'm in no position to do that. I don't have their information. There's many factors to consider that I'm not aware of. But I do have questions and concerns about some aspects of the response, and I'll be talking a little bit about that. And it's mostly about availability of information, transparency of explanation and rationale, and willingness to allow diversity of discussion and questions about policies and interventions. So, yeah, I always try to make it clear that I come from a perspective of bias and conflict of interest, as I think we all do. I'm a privileged white male descendant of European settlers to Turtle Island or North America. I'm in the top 1% income bracket. Although I'm at the bottom 1% of that bracket. And I'm going to say I make my living largely based on public concerns and fears regarding infectious and other diseases and injuries. Increasingly, in the academic and other settings, a land acknowledgement starts off because of the history of Canada. So 500 years ago, white Europeans came to a place where Indigenous people had been living for tens of thousands of years. And it's a long history of colonization with very deep and profound harm. And we're in a process, hopefully, towards truth and reconciliation. But I want to emphasize that much of this profound harm is manifested in health and education issues. So I won't go into more detail about that, and probably I don't need to. So I've already done the introduction. I'm going to give you a summary of my main points in case I run out of time, and I'll talk about the following list there as we go through it. So this is my thinking, which is maybe more for a lay audience than the group that's in this session. But bugs and diseases, they come and go and they come back, and they're here to stay, I believe. I don't think our approaches should be primarily, in some cases, even at all, trying to prevent exposure to them, and certainly trying to eliminate them. Maybe other than the smallpox story is impractical and maybe a distraction. These bugs have evolved over millions of years, and for human-to-human communicable diseases or other modes of transmission, the home and the school settings are the two most important settings for transmission, spread, and impact. The fourth point is that public health actually achieves very little as an organization itself. And I think its most important partners are parents and teachers. And the fifth point is that the parental authority for public health is government. And I'll talk a little bit more about that. But the next complicated point is really, I guess, the most important in my mind, is that this and the pandemic, I think, and the response to the pandemic has really shown this. This is very complicated. It's very complicated biologically and socially and politically and economically. And figuring out how to balance benefits and harms is not as simple as vaccine effectiveness and side effects. It involves many perspectives, most of them outside of the world of public health or medicine, because that's what the impacts are of the response to the pandemic, in addition to the differential impact of the biology and the disease itself. So this is a pretty broad and deep problem and challenges everybody to engage. And not all public health decisions are good for all of us, just like education. And so to achieve the shared responsibility of all, I'm going to say depends on learning how to play fair, a kind of phrase I first learned on the school grounds, and to think critically, something I do not believe I learned at all in school. And I think that may be the biggest problem facing us. Okay, prevention, population, perspective, partnership, capital P power. And you'll see at the top, public health first is in lowercase and then uppercase. I think it's very important to distinguish these two elements. General public health, lowercase, is everybody's work. It's broad and deep field. Capital P, capital H, public health is government legislated practice of public health. That's what I'm talking about. And of course, the power is largely rooted in public health acts and legislation, but ultimately it's government that's accountable, especially for the big decisions. How do we work in public health? At the very lowest basic level, we educate people about the facts. We encourage them to do things we think will make them healthier. We entice them with material rewards or incentives or disincentives. We bring in laws about what they can and cannot do, but ultimately changing the environment, the norms, empowering, I believe, are the most effective methods. And all of these levels have played out, and we've seen them in the pandemic. On what basis are decisions made? First and foremost, burden of illness, descriptive epidemiology. What do we know about causes? What do we know about risk factors? What do we know about distribution of risk? That's mostly in place and didn't take long to establish. Experimental evidence of efficacy, we have almost none of it for the responses for a pandemic, whether it's masks or distancing or all sorts of other measures. Very little, if any, experimental evidence. So it's an observational effectiveness, debatable, difficult to research, difficult to test, and therefore we're left with our best guesses or estimates of what might work and to what degree it might work. Cost effectiveness, no one's talking about that with the pandemic. It'll come out in later analysis. Have we achieved equity, fairness? Debatable. To what degree? So, this work, I'm sitting on the shoulders of Poland and McCall and others who talked about the settings approach. Brilliant thinking, very practical, very useful. I'm still trying to figure out exactly how to apply it. I probably don't need to talk to this audience about what a setting involves: social environment, the natural environment in which it exists, and the built environment of all the things that humans have made. It's places where we can promote health. It's places where we can cause or have caused to us diseases or injuries, whether it's a workplace setting or abuse that happens in the home, or bad education or harmful education in the school. But on the positive side, all of these are great opportunities and the only places really where health promotion can happen on the ground in the real world, every day, every place. So understanding the accountability for setting policies and what happens in each setting is a hierarchical or circular way of understanding it. Laws and policies at the highest government level that filter down through ministries of education, et cetera. But at every level, there's more local authority, parents in the home, teachers in the classroom, principals for the school. You know this stuff better than I do. The natural environment, First Nations, communities in the north, that's a road in front of those buildings. It's frozen because it's on the lake, and you can only use it for a certain period of time. And then you have to wait while it melts before you can take a boat in. And that's an example of a huge impact of the natural environment on health, supplies, etc. Here's a built and social environment of the same community. I don't have to talk about what's happening here. I think it's worth noting the window that's been closed off and the impact of that potentially on fresh air, something we're very interested more than we ever were about indoor settings. I don't know how familiar everyone is with the Ottawa Charter in 1986, talked about creating supportive environments. It listed 9 prerequisites for health. These have all mostly been sanitized in the determinants of health, which are more neutral in their wording and do not involve ideas like peace, social justice. I mean, this is a different level of prerequisites. These are not listed in alphabetical order. So after peace and shelter, education has been listed third. I've just suggested in brackets what's the primary environment that pertains to this, and I put social environment in education. But in other places, it's the natural and the built environment, which may be actually more significant. So why do I say that education can be harmful or that even public health can be? Well, I don't know how familiar you all know about you are with Indian schools. Dr. Ryerson, we just changed the name, we at Toronto, others changed the name of the Ryerson University because of his involvement in residential schools. No social distancing, difficult to do under these conditions. What's being spread here? Tuberculosis. The predominant cause of death of children in residential schools. Here's what they learned. Education, and of course, and that the point of that is got to do with the role of churches in the schools, and there's been more publicity about that now than probably ever before with the Pope's visit, etc. You're all familiar with this list of the opportunities for collaboration and the importance of them between education and health. Something I don't think is made as clear as it needs to be, and this applies, in my opinion, to almost every infectious disease, comes back to the tuberculosis example. We're all exposed to the bacillus that causes tuberculosis. We don't get sick from it. We, middle-class people, healthy people, people without immune suppression or AIDS, are exposed, but not susceptible to serious infection. And understanding this chain is, I think, critical to understanding strategies of public health with regard to infectious diseases. Healthy person, a mayor in London drank cholera in water, he had a day of diarrhea, and then he was fine. Just an anecdote to make the point. So here is some data about children. I mean, it's very interesting to talk about children, the vulnerability of children, the importance of vaccinating children, not only for their own health, but for community spread, both of which are debatable in terms of magnitude. This is the most recent cumulative data over 2 years and 2 months for children under the age of 19. Those are the numbers. I'm not saying they're high or low, but what we don't see often is even a fairly simple arithmetical portrayal or description or education about what this means in a population of 8 million people in that age group. So based on these cases, which are no doubt an underestimate of cases for a variety of reasons, especially in the most recent Omicron variant period, 1 in 25 children actually have been reported as a case, and 1% of those cases have resulted in hospitalization. That's on a population basis, 1 of every 2,500 children. 600 of those, so 10% of them ended up in intensive care. That's 1 in 1,000 cases. That's 1 per 25,000 children. 44 deaths, debatable about how many of these deaths are primarily attributable to COVID because of changes in rules of death certification and for other reasons. 1 in 350,000 children so far per year. So I've adjusted for the time period. And that's 1 out of 15,000 cases. High, low, debatable. True, false, I don't know in terms of accuracy. This is 2020 data. Infections counted for, from a variety of different things, 26 deaths out of 616. That's Canada. That's not other places in the world. Injuries, #1 cause of death. If there were 22 per year COVID cases, maybe that infection number would be double. I'm not going to tell you a percentage because it doesn't really matter. This is the settings framework and a few examples of different types of diseases of infectious nature. And what their sources are is what's important, because there's many waterborne infections, but we don't think about each specific one. We think about filtering, boiling, treating water. Same thing with food. We learn how to handle food because of a number of different things that could make us sick. Treatment is more specific to the disease. Vaccinations are more specific to the disease. Whole bunch of sexually transmitted infections. Condom and other protection is for all of them. Respiratory. Well, we're learning a lot about respiratory viruses, or we knew a lot, but people are getting more informed about it. And these are all the different measures, and thinking about the natural environment, the built environment, the social environment. What are the opportunities for intervention?
Joel, we need to wrap up as soon as you
Okay.
can, please. Thanks.
Is this my 3-minute warning as I asked for? It doesn't sound like I got a 3-minute warning. Okay, let's go faster. Can I have a minute?
Sure.
So these are problems which I think need to be solved, keeping outbreaks in perspective. So there's an interest in what can we do to prevent outbreaks. That's important. But my concern about what's happening, what has happened, what's happening is about keeping things in perspective and understanding what it means to follow the science. There isn't one science, there's debate within scientists, understanding that public health doesn't make big decisions like this, that they're made by government, tolerating questions and other perspectives, etc. What's the solution? If you know the 7 teachings, it's all about honesty, wisdom, truth, humility, love, bravery, respect. It all adds up to trust. Without public trust, I don't think much of our work will be effective. So learning to think critically and asking questions for me is what the education system needs more than anything to contribute to public health practice, prevention, and control of diseases. And I won't go into that more. I've already talked about what my main points were. I'll finish with this book. I hope everyone's read it. If not, it's a $12 book. Frankfurt is a professor emeritus of philosophy at Princeton. I hope this is on the curriculum reading requirement of every school. It's about how we think, how we talk, what motivates us, how we use facts that we choose, either truthfully or lies, for what we're trying to persuade or sell to people. I think it's a brilliant book. It ends up with challenging us. Do we really know our own motivations or our own conflicts of interest? That's it.
Thank you, Joel. That's a really good start, a real social and political and philosophical context for us to work within and discuss. I'm going to reclaim the host momentarily, and then I'm going to pass the microphone over to Peggy. So let me just get the right button.
Do I need to give this to you, or you can take it?
I think I just did, I hope.
Okay, good. Yeah.
And Peggy, you should now have control of your screen, of the screen.
Okay. Yes, I think I do. Hi, everyone. Myself and Heather Piercy are here, and Doug had reached out to ask us to give sort of an overview of the vaccination program that we have in schools. Our province, which is within Canada, has been in the news recently because of our high vaccination rates. So I'm just going to share my screen. I think.
And we see it. Yeah. Just need to start the slides. Yeah.
Okay. So as I said, my name is Peggy Rabasha. I work in the Department of Health and Community Services. And I'm a health promotion consultant, and I'm responsible for school and community health. And Heather, if you're on the line, do you want to introduce yourself?
Sure. Morning. So I'm Heather Percy. I'm a colleague of Peggy's, and for most of the pandemic, actually, I worked in one of our health authorities here in Newfoundland and Labrador as a public health nursing manager, and now I'm with the ministry as senior manager of public health.
Thanks, Heather. And Heather kindly joining me in case there's any questions around more of the public health side of things and the vaccination side of things. So this is a map of our province. We're on the east coast of Canada, and a pretty large area with a small population. So just for some context of how things have worked within our geography, we have a population of approximately 500,000 people, and about 200,000 of those people are here in the St. John's area. So that's the capital city. So most of our population is here, which means we have a large population of rural and remote communities, and cluster within sort of one quite large urban center.
Peggy, I'm just, the slides are still in the slide mode on my screen. I'm not sure if everybody's seeing it differently. If you wanted
No,
to,
that's right. That's how I'm seeing it too.
So did it progress to, do you see a map?
No, we didn't.
Yeah,
Oh.
now, but it's just, if you, over the left-hand side, if you start from the beginning, that one there, yeah.
So do you see that first slide?
Yes.
Do you see the second one now?
Yeah, but it's just in the small mode. It's not in the full screen mode.
We're just seeing your speaking notes mode there.
I think if you click
now.
on,
I've got two screens. That's maybe, how do I get out of this?
you might still be on your computer, so to speak.
Can you click on from beginning at the far left of the upper, as Doug, I think, was saying, you're in the slideshow option.
Display settings.
Right over to the far left under the word file. There you go. There you go.
I don't see it.
Okay, we do have the Newfoundland map now on the screen.
Oh. So do you see the map there?
Yes.
And do you see the school, community health nursing?
Yes.
Okay. And then you also see the next note?
Yes.
Okay. Is that all right with everyone, your view?
Yeah, I think it's pretty clear.
Okay. So within the geography, our province is broken up into 4 regional health authorities. And within the health authorities, they look at the local context and do planning based on what the needs are within their communities, and also looking at the geography. So the vaccination programs that we have in Newfoundland and Labrador have always been led by a strong public health system. So public health staff have an established trusting relationship within the communities they serve, which allows them to support families in keeping their children healthy through a partnership with that education system. They've really built that trusting relationship within the school administrators and the school staff. So supports that are provided by our community health nurses or public health nurses within the schools are listed on the slide that you can see. So they support school communities in disease prevention and management. So it could be hand washing lessons, head lice, scabies, for example. They provide education to school staff and to families. They promote healthy eating, healthy behaviors, healthy lifestyle choices. They provide immunizations according to the provincial immunization schedule, and they can refer families to other service providers if necessary. So that can include optometry, lifestyle clinics, an array of different services that can be available. So the way it works in our province is that the community health nurse will be assigned to either a specific school or a small group of schools, depending on capacity and depending on the geography. And that allows them to build trust and understanding of the strengths and challenges and needs of their schools. So this allows the support offered to be responsive to specific school needs. So for example, a school that's in a remote rural community may be seeking support around food security, whereas a school in a school community, more of an urban setting, might be interested in having some support to address an increase in vaping among youth. So that local support from the community health nurse allows interventions to be meaningful and targeted to address a specific need. So this is the benefits of public health-led immunization in schools. So we enjoy a high uptake of immunization within the province. The system works so that young children aged 2 months to 5 years will receive their immunizations from a community health nurse at a local health unit. And school-age children are offered immunization programs delivered by community health nurses in special immunization clinics within schools. So the benefits of using these local community health nurses are listed on the slide to administer vaccinations in all schools across the province. The first one is that equitable access. So equitable access to vaccinations for all youth across the province. All children within our province can avail of free education, and government is responsible for their transportation to and from school if they live outside of that 1.3 kilometer radius of the school. So this means that all children are within that setting. So it's a great environment to offer a vaccination service, and that way you can access all students. Using the school as a setting for youth vaccination clinics reduces inequitable access that can be caused by various factors, such as the inability for travel. So parents, there may be disability, conflict in work schedules, or lack of transportation. There could be issues with internet access for booking appointments, or internet access at all for some of our really remote communities. Health literacy could be a factor, language barriers, etc. So there's a large array of reasons that clinics may not be visited as equitably if it wasn't in school. The community health nurses are also a trusted part of the school community. So in some of the smaller regions, it's the same community health nurse that provides support to families across the lifespan. So this can include prenatal, postnatal support, healthy beginnings, parenting education, healthy baby and breastfeeding clinics, preschool health checks, and healthy community development. So the public health nurse for some people is that first point of contact. As a result of this, the community health nurses build relationships with families and communities they serve. So this trusted relationship may be one reason we do not really see that culture of vaccine hesitancy or distrust in our province. Collectively, our rates of childhood or school vaccinations are around 90%, maybe a little bit higher than that. This trusted relationship may also have been a factor in our COVID-19 vaccination rates, which are currently at 92.4% for ages 5+ in our province. If anyone's interested in the breakdown, that's on our government website, and there's a lot of age groups that actually have 100% with adults, and the age is 12 to 18 years and our seniors. So this slide just shows what that school immunization schedule looks like. So grade 4, grade 6, and grade 9. Some of those vaccines will have 2 doses. And the process, the way it works is where the community health nurses are assigned schools or a couple schools, they will case manage those schools for these vaccination programs. The community health nurse will know the vaccination needs of the students in their assigned schools. They communicate to families about upcoming school immunization clinics. They collect the parental consent forms, and they follow up with the students' families who may need alternative or additional supports. So this system, there's not a lot of extra work for the administrator. It's just the administrator is aware, and he would also, let parents know that this is going to be offered. During the school immunization clinics, a team will support the case manager to administer the vaccines. So this team can consist of registered nurses, licensed practical nurses, and administrative support. The role of the administrative support staff is to organize the room, keep the flow of students, and support students in the post-immunization areas. And then once the vaccination clinic has been completed, that community health nurse will enter the student immunization data for records. So I've talked about the role of the community health nurse in the vaccination support, but our community health nurses provide more support to schools that goes beyond just the vaccinations. And to support their work, there's a team of health promotion consultants that are topic area specialists. So it could be a regional nutritionist, injury prevention consultant, parent and child health coordinators. So we have an array of health promotion expertise. And they can provide the latest information, and they can provide a consultative service to the community health nurses to help inform their work, make sure it's in line with evidence and best practice. We also have positions across our province, and it's called the School Health Promotion Liaison Consultants. And they work in both the health and education sectors. So they are seen as internal to both, and they are more specialized in that school setting and the health setting and how the two go together. So the acronym is SHPLCs, which is doesn't roll off the tongue, but they can support the community health nurses, and they can support other people in this health sector to understand that school setting. And that includes the organizational structures and how decisions are made within the schools, within the school districts. They also link all school health promotion work to the comprehensive school health framework. So these SHPLCs, they're really key in the support system with the health and education. They understand the structures, the priorities, and the languages of both the health and education sectors, and they can work to facilitate an effective collaboration between them to create healthy settings. So between the community health nurses, the SHPLCs, they work together along with a team of health and school district staff to promote health in school communities. So they're really actioning that healthy settings approach. And one of the big factors among all of this work is that relationship building and allowing flexibility for schools and using those local resources and connecting things to that local context. And that's my last slide.
Great, thank you very much, Peggy. Heather, do you want to just add any comments before we move to the next presentation?
No comments per se. That was a great overview by Peggy. If anybody was interested in the COVID statistic for children, I'll just point out that for regular vaccines, we do have a high rate of vaccination, and we did as well for COVID. And in terms of the setting, we did a bit of a hybrid for how we offered COVID immunization to school-age children. And we offered in the school setting in the same manner that we would offer the regularly scheduled vaccines. And we also offered through clinics in evenings and weekends for parents who wanted to avail of that type of setting.
Excellent, thank you very much. I'm going to just pass the mic over to Daniel and Mark. You should be able to control share your screen now.
Okay, can everyone see that?
Yes. Yep.
Excellent. There you go. Thank you very much. So I'm just going to start. So thank you very much for inviting us to speak to you today. I'm Mark, and this is Daniel, and we're from Cambridge Partnership for Education. We're a unit within Cambridge University Press and Assessment, which itself is part of the University of Cambridge. Our remit at Partnership for Education is we support ministries of education through donor organisations or through direct engagement with education reform projects in a wide range of areas, all the way from assessment to teacher professional development through to curriculum. So as part of our work, we're in a very fortunate position that we get to look at a lot of national curriculum frameworks. We get a lot of insight into different countries and different regions in how their schools operate and how they run and what they value in their curricula. So from that work, we have the opportunity to look at hygiene and disease prevention in national curricula, because we start to identify trends in a lot of the work that we do. So that's what we did. We had an exploratory study which looked into the content in various frameworks. And we have a paper that goes with this that was on your reading list. So next slide. So so yeah, I'm Mark. I'm currently head of professional development solutions in Cambridge Partnership for Education. I was previously a curriculum programs manager when the paper was written, and since then I've gone into my role looking at PD of teachers, which is really related because there's an ongoing question about public health education. Public health is really important in education, but how do trainers, how are teachers prepared for it? And I've worked in various regions, particularly in Africa.
Thank you, Mark, and hello everyone. So I'm Daniel, and I think probably the key thing to emphasize in terms of our introductions is that our background is very much in general education. So kind of the sort of the standard national curriculums that are being used in the different countries in which we work. So I'm going to take you through sort of the methodology that we applied and some of the findings that we had in our paper, and then Mark will talk a bit more about the implications of that. So, as Mark said, we're quite fortunate really in that we get engaged to work on a national curricula from around the world with various different governments. And we responded to a call for some papers that were interested in what the curriculum response to the COVID pandemic might be. And we were very aware from our work that quite often when these sorts of new social demands for changes to the curriculum come along, they're not always necessarily informed by what's actually in the curriculum. So as Mark said, this is a very exploratory thing that we did to basically go out and see, well, people are saying we should change, but let's go and have a look and see what's actually there already. We were obviously responding at sort of some pace because everybody was in the early days of the pandemic, and we just migrated towards the curricula that we already had, that we already worked on before and knew quite well. So we looked at the 5 countries you can see on the screen: Ghana, Kenya, Kuwait, Estonia, and Australia. These had the advantage of being English, or it being published in English, so we were able to access them quite easily. They're also published online, so anybody who wanted to sort of go and check our work would be very welcome to go and do so. They also all fit with some sort of general trends in national curriculum development, in that they were increasingly thinking about competency rather than sort of, I guess, content. And they were also all increasingly interested with sort of cross-curricular learning. So rather than sort of seeing everything as sort of defined within sort of strict subjects, they were also starting to think about how they might articulate what needs to be learned across subjects. So we took these curriculum documents and we effectively built up ourselves a sort of a reference list of terms that we would associate with public health, with vaccination, with disease prevention, and basically went looking for those terms and looked to see where that was being located. Our sort of starting assumption being that quite often it would be associated with the science curriculum, because again, one of the things we were quite aware of is that a lot of the calls for change were not necessarily to do with public health per se, but to do with maybe scientific literacy. So sort of we were seeing the sort of the contrast between health literacy and science literacy. And then the last thing I'll say about this is you can hopefully see from the table that the countries that we were looking at have quite different contexts. So this was based on some sort of UNESCO data that was available at the time that we were writing the paper. And you can see the sort of the level of investment in both health and education was markedly different, and therefore perhaps naturally the outcomes in health and education were also markedly different. In the interest of time, I'm not going to take you through all the findings that we had, but as Mark said, I think the paper's been added to your reading list so you can read more. I'm just going to sort of pick out the 2 sort of extreme cases. So case 1 is Kenya. So Kenya is one of the countries with, I guess, a lower investment in education and health, and perhaps poorer outcomes in both education and health. So perhaps it's understandable that you find an awful lot about health in their general education system, to the point that in their primary curriculum, it's actually its own subject, and nothing sort of signifies to an education system that something is important, like saying, here is an entire subject for which we are going to recruit teachers to convey this to learners. So they have a specific subject around hygiene and nutrition in grades 1 to 3. So that sort of this is very early stage of schooling. They also then have quite extensive content as they move into grade 4. So Kenya is currently undergoing reform in its curriculum. So at the moment, only grades 1 to 4 are available in the new format. But it's clear that health is going to continue to play an important part, because they, as I mentioned before, these curricula are all looking at cross-curricular themes. And in Kenya, that's expressed in what they call the pertinent contemporary issues. And you can see the sort of the influence of a desire to have education at the centre of everything in these. So I'm afraid I struggle to remember exactly what all of these pictures are intended to indicate from when I first put this presentation together over a year ago. But I remember that, for example, in maths, when they talked about time, they would talk about the time it takes to clean your teeth. When they're in music, they would talk about how you keep your instruments clean. I think that the children, there was a subject, I think it might even be in religious education, where they talk about the family and different levels of relationship and different levels of appropriateness for sharing food, drinks, etc. So in Kenya, it's very, very important, and it's given its own subject. And we can contrast that with the sort of the other extreme, which is perhaps Estonia, although Australia is another case which actually probably would be more relatable to the Canadian approach to education, I would imagine. But what we found interesting about Estonia is they very, very squarely see health education as a consequence of science education. So there's very much an expectation that what you learn in biology and what you learn in chemistry gives you the scientific understanding that is necessary to understand public health messaging. So there's, and that was unique to Estonia in the countries that we looked at. No other country quite pegged health education to science education in quite the same way. So two very different contexts, and as I say, two very different sort of levels of expenditure and two very different health outcomes. And I think that reflects, therefore, the way that they have approached this in their general education curriculum. So, Mark,
yeah,
hand over to you.
And so what we get with this is thinking about, well, what does this mean? And so Daniel highlighted two extremes. There is a spectrum that goes across that as well. I'm going to talk in broad terms. So first of all is when we start thinking about curriculum and how different countries approach it, they are operating already within a system that exists, and any inclusion of health education, whether that's a new subject or within existing subjects, there's already an existing curriculum that people have got to deal with. This isn't based on any one country. This is just sort of a feel from based on experience about how curriculum are generally organised. So you have a significant amount of time spent on languages, a significant amount of time spent on mathematics. Sciences, particularly in secondary level, when you start breaking it down into biology, chemistry, physics, earth science, and things like that, it takes a significant time. And then the rest generally is accommodated through the humanities, geography, history, arts, and then other subjects, particularly things like personal, social, and emotional as well. Oh, we lost it back. There we go. There we go. Can you see that? Hopefully you can see that okay. And when you start thinking about health education, you've got this finite space. So one of the implications of what different countries do is what decisions have they made in order to accommodate their messaging or their approach to health education? And there's different approaches. So in some countries, it is insert health education with existing subjects. A little bit like Estonia, you focus on the sciences, or you focus on the humanity aspect, or you focus on the other, like personal, social, emotional need. And you say, we are going to put in content around health education within these subjects. We can do what Kenya's done, which is put in a whole new wedge, a whole new subject. However, whatever you do, you then distort the rest of the shape. You distort the rest of the curriculum. What are you removing? What gets squeezed? What are you changing? And that then has consequences then for national ambition, particularly in the context we work in, which is supporting ministries for educational reform, because a lot of the ministries that we support, a lot of the countries we work with, they are very interested in international tests like PISA and TIMSS. And there's a tension there between PISA is asking us to teach this content. This is really important health education messaging that we need for our context. How do we get both in? And there's a real pressing desire there to be international at the same time as serving their context. So one of the implications of what we found out is, how do you make these decisions? What decisions do you make? How do you balance these different competing goals of a government at a national level for the needs of their education system? And how do you look, health education is important, but you have to look at the entirety of education as well. How do you get it working effectively? And then that leads into a question about what learning should go into a curriculum. If we're talking formal school curriculum and health education is going to have a place, what does that mean and look like? And from the examples we looked at, there's sort of two competing extremes. One is public health messages versus scientific concepts. So a little bit, it's like the difference between the message of keep your hands clean versus why is it important to be hygienic? Do you teach like Estonia why it's important to be hygienic and then they understand why it's important to keep your hands clean? Or do you focus on the public health messaging, like in some African countries, of this is just really important, please do it? The same with get vaccinated versus how does vaccination work? And what's really interesting on vaccination is when we did this study at the time, it was only one country who had vaccination in our list who included vaccination in their curricula. The others didn't. So it's going to be really interesting to see if there's a change in the future from COVID, if COVID is going to lead to a change in curricula. But again, why? Because do you react quickly to the pandemic and change your curriculum, which might last for 10 years in response to an immediate issue? Or do you try and be more strategic and targeted in what you include in your curriculum and why is that there? So again, there's this tension between what's best for the public in the short term versus what should a curriculum long term look like. And it's these tensions that really interest us as curriculum designers and educationalists. And then from that, there's questions we still think about. So things we still think about and still question is there a place for health education within science curricula? Is it science really where it belongs, or should it be its own thing? And if it's in science, what does that mean? How much health education is the right amount? Because that's really contextual, because some countries have very pressing demands on their health system. And there's a lot of diversity. So in the UK, where we're based, there's still a debate around healthy eating and obesity and sugar. We don't have as much debate around infectious disease as maybe we should have, and that's potentially why we weren't as prepared for COVID as maybe we should have been compared to some African nations where infectious disease is really prominent in their curriculum already because of malaria and other things like that. Should there be more focus on public health messaging instead of scientific understanding? And about how do you make that judgment call? Does that downgrade the curriculum? How do you assess public health messaging? If that's going to be in your curricula, which is a really interesting question. Who's best placed to decide what health education goes into the curriculum? Is it an international organization like the WHO? Is it governments? Or is it should it be more localized? Should it be down to schools and teachers to decide who makes that decision about what's important and at what level? And then interesting from the pandemic as well is what about mental health education? Because the pandemic's had this real big impact, and there's plenty of research out there around the impact of mental health on children and adults. So how do you recognize mental health within your curricula, which generally doesn't get recognized? A lot of it's on physical health and about infectious disease, but mental well-being is not so recognized. And what support do teachers need? Because it's great saying, let's have this in the curriculum, let's change our curriculum, let's put this new plan in place, let's really improve public health through formal school education. But what do the teachers need who are delivering it? What understanding do they need? How do they teach the lessons? How do they integrate that? So there's a whole point around implementing a new curriculum, not just designing it. And that's sometimes where things get unstuck. It's what resources that take and how long does that affect? And these are still questions we raise when we talk to people we work with, when we talk to governments and we talk to donor organizations around curriculum reform. These are the questions we explore in our work. So we wanted to share that. All this is linked to the paper, which we've both referenced, and you've got the link to that. And hopefully that gives you a little insight into what we were finding, and also a little bit of sort of things that we asked during our work, and I hope that's useful and interesting. And if there are any questions, we would welcome them.
Excellent. Thank you very much. I'm going to ask you to leave that slide on the screen because I think it's a good set of questions that perhaps we could also take over to the public health system, and in terms of Joel's presentation and also in Peggy's presentation, how the merger or the linkage between health and education in the province of Newfoundland and the public trust in the role of government in community context. I think that's a really good overview of the complexity of even taking a simple thing like trying to prevent infectious diseases through schools, and how it needs to work through several systems working together. And that's where the complexity certainly comes in. So I'm going to open it up for comments and questions. Please jump in. If you wanted to turn on your screen so you can wave your hand, or there is a little raise your hand button, and I'll try to keep tabs on. But if people just click on your screen, then I'll be able to see you waving your hand the old-fashioned way. And maybe I'll start one of the project. one of the
It's
projects-
Joel. I'm sorry to interrupt, and I know I've already done speaking, so it should be up to others, but you may notice a flashing of light behind me. It looks like I'm in an apartment block, and it looks like this is a fire signal.
Oh, gosh.
So I may have to dash off. I'm going to hang in here because I know there's just a couple of minutes. But while I've got the floor, I have to clarify one thing that I said, which was those numbers I was giving. What I didn't say is what they might have been had there not been public health interventions, vaccination, and all the other measures. And that's a really important point. I just wanted to clarify.
Great, thank you, Joel. And that is reality intruding here in terms of complexity. For sure, you're in the middle of a fire alarm. Please, questions or comments from folks, please just click on your mic and introduce yourself, your name, and just ask your question or make your comment. Well, maybe I'll start with it's a bit of a systems point of view, but the Mark and Daniel's presentation, the competency movement in education is very strong, and it's growing right around the world. And I don't think as health educators or as advocates for health education, we've understood the implications of that. And one of the underpinnings of the competency movement is a constructivist approach to education, where people construct meaning rather than being told which behaviors to follow or which knowledge to accumulate. And it's a slow moving train, but it's still moving. And I think it's important that we understand it and adapt to it in terms of how school systems will change. And so, whereas in the traditional health education, it is a behaviorist approach and very, the wash your hands and so on, as one of the slides indicated. So I'm hoping that as we move forward, that the time and place of which in the curriculum will decide on the local country context, or even the provincial context, and even maybe in the local community context. So it's and one thing I learned in a previous life as a teacher union leader, where I thought it was really political when you went out on strike, the politics of education are actually more profoundly attached to curriculum than anything else in the education system. Is what kids are learning, and that's what's most at heart. So I think that's it's a really interesting discussion about going through that, but it's something that we need to think about. Questions? Go ahead.
I was going to say in response to the competency thing, because we see a lot of governments and moving towards competency-based education, a lot of systems moving towards competency-based education. There's still some debate about what exactly that means and looks like and what that covers. And for some people, it's quite transformative. For some people, there's a bit of a misunderstanding and they tend to reinvent the wheel. And I think there's an argument for that in some of the literature that we see. I think what it's about is what's right for the context and the country. And they ultimately, even when they go for reform, they're doing what's right for them, and that reform is valuable in its own right. It's a valuable process. How do you realize competencies, and how does health education fit into that? Is, I think, a really outstanding is a question. It's an outstanding question, and we often have these conversations with those we work with. Quite often, when we go and engage with curriculum groups, we're talking around competency education. We're talking about skill development, and what does that mean for different components. In health education, you have got this tension between knowledge that sits behind messaging and the message itself, like we were saying, that tension between public messaging and scientific knowledge. But even then there's this really interesting knowledge debate around what do you mean by knowledge. In the UK, there's our alarm going off. There you go.
Joel, I will excuse you if you have to run. He may have. Okay,
I'm sorry. I'll leave it on. I forgot, is this an hour or an hour and a half?
We were usually aiming for about an hour, but we often run over. So if we wanted to, we'll stay for a while as long as people are interested and the speakers have time.
I'll come back. I'll come back if I can.
Okay. Oh yeah, you may, with a fire alarm, we probably were going to be finished before you come back. But so don't come back into a burning building, please.
Well, I'm sorry I have to leave before people criticize my talk. So just keep a note of all the things people say, so that I can learn from it. Thank you. Thanks, everybody.
Great. Thanks, Joel. Be safe. Questions and comments? We have a couple of people online.
I'm very sorry, we're just having to move room, but we'll just keep listening in.
Okay, one of the things that we're going to work towards, and this will be through the FRESH partnership, and if you read through the other infectious diseases, I would recommend the paper that Joel and his colleague did 7 or 8 years ago on the infectious diseases in the school setting. And that paper outlines the components, the sort of core components of vaccinations and education and other elements that we normally talk about in comprehensive school health, the pieces that form and so it's a good start of the project, which will be to lay out those core components the way we traditionally do with any other health or social issue. But I think as Daniel and Mark have indicated, there are other systemic issues, the capacity, the context, the process of implementation. We have a little acronym in FRESH, IMSS. It's implement, maintain, scale up, and sustain. And that's a process that takes a long time. And Peggy, and you'll know about how the school health program in Newfoundland has developed over the years, and it's not done overnight. And so I think it's a process that you have the simple sort of interventions you want to be able to deliver it in a sustained way, but then you also are working in the real systems, and there's negotiation at every level. So that introduces a thought we might talk about. We will be doing it, and we'll be doing it through the FRESH partnership, but we also have a website, Schools for All, schools-for-all.org, which is kind of a Wikipedia for school health and development issues. And we'll create a page on infectious diseases there. So we'll be building the knowledge, we're collecting the many references and resources available, put them in, and as part of that, and Daniel and Mark, I'm hoping I might talk to you again. Well, actually, all the speakers is we're doing a project with UNICEF and UNESCO. We're doing the kind of work you did in 5 countries. We're trying to do it for, and this is where it gets scary, all countries and all states and provinces, to collect all their curriculum documents, which, as you know, you've done it. It will be a massive job just to get the list of documents. But we're hoping that might entice researchers like yourself to be able to examine these kinds of curriculum issues the way you did in your 5 sample countries. Maybe we'll talk again for sure. Comments? Have I provoked any discussion?
I just wanted to make a comment to what you said, Doug, and that what we have found is that the relationship is key for promoting health within the education sector. We want to avoid the education sector thinking that's health. They'll do that on their time. We're looking at, math and science and whatnot. And the co-curricular focus of health is sort of where we've been looking at within our province. And also that healthy setting is really key in extending those lessons beyond the classroom. So if you're teaching students about healthy eating and they go to the cafeteria and there's healthy food choices there, that's just reinstating and it's allowing them to practice those behaviors within that school system. We're trying to move to a space where when children go to school, it's the expectation that it will be a healthy space. And that would include options for physical activity, food choices, injury prevention, the natural, the built, the social environment, like all that is being supported by them being in that environment. And I do have a question for Daniel and Mark. When you're looking at the curriculum in these different countries, was there any information on the impact on behaviors or the impact of the health status of these curriculums within these communities? Did it change anything within them?
It's a really good question, Peggy. The answer, unfortunately, is no. We don't have that information, largely because actually all the countries we looked, I mean, by virtue of the fact that they'd come to work with us, they are changing their curriculum. So actually now is the right time to be asking those questions. But as far as we're aware, I don't think they are being asked, and I don't know if the data is available. But it's really interesting to hear what you were saying about that sort of co-curricular space. I mean, that's something that we talk a lot. I don't know if you're familiar with the term of the hidden curriculum. So this is something that we used to describe exactly what you were talking about, sort of the wider environment of the school and how the sort of the behavior and the social norms and just the design of it all. I guess, you know, I was quite interested to hear that sort of thing about the settings approach. I've not come across that before, but I can see the sort of the parallels there with I say what we term the hidden curriculum, and how powerful that could actually be for improving understanding of health.
Maybe I'll just jump in on that, because I think that's one of the things that might be going wrong with the responses to date to the COVID pandemic. Is it's being turned into a mental health issue for teachers and students, which is true. You know, there are mental health consequences, but I think what's missing when kids don't go to school is their social and emotional development, which is a broader term, broader than mental health. And that's where extended, there's a jargon term used by a group of researchers we've had contact with. They call it extended education. It's all that co-curricular, extracurricular, outside in the community, all the things that can online, all the kind of informal learning that can occur. And I think our project, well, not only this project, but others, will try to look at, can schools and communities and parents take a closer look at how all of those different informal opportunities to learn can be better organized to support the social and emotional development of kids. And to think about that as a concrete outcome in terms of, you know, how many programs, activities are kids engaged in during the week? You know, how are they able to have enough opportunities to make friends and to keep friends? And those, and I think that's the experience coming out of COVID, where that was missing in kids' lives for a couple of years. And it is a mental health consequence, but I think it's social and emotional. And of course, there's the work that's done. There's a big alliance on that worldwide. And the primary paper done by CASTLE, it's a group on social emotional learning, makes that clear, that it's that focused work on developing social emotional skills and knowledge and attitudes that we need to really, I think it's one of the things we've learned from COVID that's not yet becoming apparent to decision makers. Go ahead, Pat. Yeah.
Hi, thank you. Excellent presentations today. I just wondered, Daniel and Mark, in your research, in Canada, we now have 7 universities that are making it mandatory as part of the degree of a Bachelor of Education that the graduates all have to take a public health, comprehensive school health course as part of their degree. You know, improving their knowledge about what public health is and comprehensive school health. So I just wondered if you noticed that in other countries, or was that something you were looking at all?
So we didn't look at that specifically. We didn't look at the teacher education programs. I mean, certainly some of those contexts, you're lucky if your teacher has passed their school exams. So I think it's possibly quite unlikely that they would have some kind of additional training specifically around health education.
I will just add and say that in our wider work, when we're talking to ministries, we are having increasing conversations around the links between pre-service education and reform. So when a government's going through a period of reform, like in curriculum, the necessity to look at what's happening at pre-service to ensure that their pre-service teachers are being prepared for the new expectations and the new curricula. So we've been doing some work in East Africa recently, and there's an active conversation around, we're bringing in a new curriculum. What does our pre-service teach? You know, what do our teachers need before they get to the classroom? How do we train our teachers to ensure they can do this curriculum? And that's going to cover all aspects. So if there's, you know, there's a bigger focus on health education, that should be in pre-service. So there's things have got to keep in step. One of the things we do at Cambridge quite a lot is we talk around coherence and around the need for the whole system to be coherent. So if you're making a new reform, what are you doing elsewhere in the system to ensure that reform is successful? And pre-service is really important. But again, it's not part of our original study, but we are knowing it's something that we're talking more and more. I think people are recognizing that link, which I'm really pleased about. It's just a shame being prevalent so far. But yeah.
Okay, thank you. And I'll just say, Doug, that's the research coming out of the States right now is showing that if you focus on children's, students' social emotional well-being versus focusing on getting them caught up on all the education they lost out on while COVID was, while schools were closed, that students will fare better and they will just naturally catch up, but they have to be healthy. They need that positive social emotional well-being in order to learn. I know there are some areas where, you know, the focus is on, let's get them caught up, let's give them more math, more science, you know, they missed out on so much. Well, they're not healthy. They need that positive social emotional well-being taken care of before they can actually then focus and learn. So I know that's where the research is coming out of from the States that I'm most aware of. So.
Susan, did you want to add? Go ahead.
Sure. I'm certainly not a curriculum expert by any means, but I'm really kind of interested, Daniel and Mark, in the work that you were doing around the countries that sort of infused mental or health curriculum within the curriculum, the science aspects. And it seems to me that the systems that focus on PISA and those kinds of testing, if there was a way to implement mental well-being and some of those social determinants pieces within the science curriculum, I think that the uptake and the response from the education side might really lend itself to that. So that part of the research I found really fascinating and maybe helpful moving forward to sort of go in the back door in this kind of work.
Yeah, I think on PISA and TIMS and things like that, PISA is about to go through a reform in their science assessments. That's announced, is imminent actually. Hopefully they're going to release the draft framework for the 24 science assessments. And PISA is always adapting. So I think there's an argument for how do we influence or leverage that, and how do we get that messaging across. But I agree, you know, people care about those sorts of things, and that's a vehicle for the reform. So yeah, it's really interesting.
Thank you, folks. This has been very, very interesting. Hope a really good, stimulating start to our project. I'm going to be inviting our three sets of speakers back to the next stage. We'll form a working group, and we're going to try to be a little more realistic. I'm known for not being realistic about timelines, but we are hoping to get that going in the fall, and so we'll put together a list of the research around infectious diseases and move forward. And the curriculum piece, I think, is far reaching, or the school reform piece. As you all will know, there is a huge discussion going on in many countries and at the global level about the new term is transforming education. I'm working with a group of educators, organizations representing educators, the teachers, the school principals, the school district administrators, ASCD, a big group, and ministry officials, deans of education, and we're suggesting that group is suggesting that countries should make haste slowly in this. They have the challenges from COVID. They're trying to be getting back to what the long-term improvement objectives they had in terms of things like goal number 4 of the UN SDGs, and then we have transformation on top of it. And so that process will take many years. And there's a big UN General Assembly in September in New York, and the powers that be are scrambling to come up with some bring and brag kinds of sessions. And that's not how it happens in school systems nor in health systems. But we'll keep trying to make that point. Go ahead.
Sorry, Doug, I just want to add, and it sort of builds on the point that you were making, Pat, that I think in general education, there's a sort of a growing sense that there are these sort of prerequisites to learning. And that maybe, you know, like you say, we can't just sort of keep throwing more science, more geography, more history at kids. There are sort of certain things which are maybe more foundational than that. And particularly in sort of, I guess, developing countries that we work in, I think there's a concern that they've been too distracted in terms of, sort of, I say, general education outcomes. They've been too distracted by perhaps a kind of interventionist model where it's like, oh, everyone has to have, you know, ICT, everybody has to have this new subject. And that's kind of taken people's eye off the ball in terms of achieving, like you say, you know, the social and emotional development, or the psychomotor development even, and particularly things around literacy and numeracy, because if you haven't got those to a foundational level, it's actually almost impossible for you to access the rest of the curriculum. So yeah, I hope that the sort of project you're describing there will help to shine a light on some of these important areas.
Great. Any final comments, Joel? I see you've survived your fire. That's good. Any parting thoughts?
I think it's been a great discussion, and I appreciate the other presentations. The two thoughts that are at the top of my mind, there's no time to answer them, but I want to come back to your point, Doug, about, you know, about mitigating measures for children when schools are closed. And I just, you know, I want to emphasize the question, not my answer, but the question about whether schools need to close at all. When I was the chief medical officer of health during H1N1 influenza, there was a lot of pressure on me and others to close the schools, mostly coming from infectious disease specialists. But when we looked at it carefully, first of all, we weren't sure that it was going to change anything about that it was going to be effective in interrupting transmission. In fact, better arguments and evidence were that the kids would gather in other settings, in other places without observation, and would not really interfere with transmission at all, or maybe make it worse. And then, of course, the other thing was the negative effects of being out of school for learning and other purposes. So all I'm saying is I'd like those ideas to come into the conversation. And what I'm learning is that governments were not very effective, at least in places that I know, of bringing into the room for conversation teachers and small businessmen and, you know, a whole bunch of others who had things to say beyond the so-called science or the so-called public health science. And the broader issues that need to be considered in harm and benefit. And that links up with Daniel and Mark's work and the conversation about what do kids need to learn. And I think what I'm hearing is something like critical thinking without numeracy, without literacy, without scientific method and understanding and criticism within science about, you know, what is information, what is misinformation, what is disinformation, what do you need to know and understand to be able to do that and engage in the kind of thinking that is complex for this is very exciting to, you know, to hear that thinking about the curriculum and the other developments. So yeah, that's sort of my last questions and or comments.
Great, thank you. Peggy, any further comments or closing?
Yeah, I just had a comment to, I think Pat was talking earlier about the social and emotional learning. And I think there's a really good opportunity to I think we're doing that in this province as well, is looking at that cross-curricular and looking at different components that could be incorporated into other subject areas. So even mathematics, you can, as long as teachers understand, I guess, the rationale, if you've got the buy-in and they know how to work those components into their lesson planning, they could pull that into mathematics, into language arts, because if you're writing an essay, it could be on any topic. So why not look at something health related? There was a video that was circulating, I think it was from Castle, and they had arranged a mathematics class where the students were teaching each other that would, you know, improve their confidence and friendship. So all those components were sort of behind the scenes while they were learning mathematics. So that was something interesting that's been looked at. The other piece that I wanted to mention, and Joel, you just to go further along what you were talking about with the school closures, not for the pandemic reasons, but if you're looking at the school as a health promoting setting and that close relationship between schools and the health sector is, you know, supports that could be given to students over the summertime. So in Canada and Newfoundland, and it was closed for 10 weeks, that's a long time. So if school is the place those students go for breakfast and go for lunch and go for different supports and maybe a break from the family, what happens during those long summer months? So, you know, how can the school maybe set up a service or wraparound for those students?
Great. Daniel and Mark, any final thoughts?
Well, I maybe have one which is perhaps just a bit tangential to what Peggy was just saying. And I should acknowledge that we work for an assessment organization, among other things. And I think one of the things that assessment does show is that even in normal times, you can have quite a significant range or gap in learning. you know, sort of you can have learners who are maybe sort of 7 years apart in their development, just sort of in, you know, well, sort of normal times. So I'd like to think that, you know, particularly in well-developed education systems, you know, the sorts of things that we've been talking about here are already there and should be able to help us, you know, make those sort of catch-ups should they be necessary. So Mark, I don't know if you...
Ben, the only comment as well is it's interesting looking at global trends in where education reform, and there's increasingly a profile on early years education, especially in the 0 to 6 range. And going back to the Pat's comment around social emotional development, you know, that period is really crucial for developing children who are ready for formal education, making sure they've got the skills or the awareness to engage in formal learning. And obviously the pandemic has had an impact on children going to those settings and the ability of children, speech and language. It's in the UK media at the moment. There's a new research report that's just been come out recently about speech and language development of young children is down compared to pre-COVID times. And so what does that mean when they get to school age? And what does that mean when they want to start reading? So there's this whole ripple effect, and it starts really young. So it's really interesting thinking about health education. It's not just about what you do, it's about where do you start? At what age does this track back? And what prerequisite, and how does that all work out? And yeah, so I think there's a really interesting trend there about that question as well. Not to be discussed now, but I think that's just an interesting thing maybe to end on.
Okay. On that note, I'm gonna close the session and thank everybody for participating. I will be in touch to follow up on things, and thank you again. This is a very interesting and obviously complex area of investigation. So thank you again to everybody, and we'll be in touch. Thank you.